Let's talk about a typical scenario that you may encounter while covering the OB floor. You have a G3 P2 patient at 38 weeks in active labor. Her heart rate is 118 and her respiratory rate is 26. She feels slightly dyspneic and does need oxygen supplementation to maintain her oxygen saturation above 94%. While you are evaluating her vital signs, a colleague comes by and says that this patient's vital signs are pretty normal for her gestational age and her stage in labor. What do you say? Unfortunately, the United States continues to face significant maternal morbidity and mortality. Sepsis alone accounts for nearly 13% of maternal deaths, which is on par with hemorrhage and hypertensive disorders. Unfortunately, most adverse events are often deemed preventable upon review and are due to factors such as delayed recognition, delayed escalation, and interventions that are initiated after the patient is already critically ill. Part of the problem is so-called wellness bias, whereby there is subconscious tendency among clinicians to assume that young, healthy-appearing pregnant patients are well, even when symptoms suggest otherwise. Such wellness bias lowers clinical suspicion for serious conditions and may delay interventions. In obstetric patients with infections or sepsis, for example, wellness bias can lead to the minimization of concerns expressed by patients or even dismissal of abnormal vital signs and laboratory values. Tachycardia is dismissed as part of normal pregnancy, and shortness of breath is just due to the gravid uterus rather than symptoms of something more serious. Think back to the patient in our opening scenario. Are there signs there that would make you concerned that something more serious is going on? Stay tuned for part 2 of this series, where we will discuss more about cognitive traps in obstetric care. And don't forget to go to the February 2026 APSF newsletter to read the entire article.